Okay, so this has probably been one of my favorite graphics to show presentations over the past year or so, but this was the cover of The Economist, some issue I don't even know, but basically looking at the reform bill that was signed into law almost exactly a year ago now, I think it was a year ago yesterday, which imposes economic consequences on participants who cannot improve the access, quality, and cost of care. So building in those consequences, and designed to accelerate a crisis for providers and payers who try to preserve the status quo, focuses on cost reduction and quality improvement, the drive to tackle waste, fraud, and abuse. Demand on healthcare institutes is increasing, costs on healthcare increasing, so we need to help. We need to help in this situation. They really need us. So these are all kind of great, great ideas and great goals. I think that we can all agree on that. The prevailing market sentiment is we're going to look at improving quantity, quality, and outcomes of cost per unit, or per unit of cost. Phasing out fee for service and tying payment to value. So more performance-based, looking at outcome metrics, process metrics, hospital-acquired infections and readmissions, punishing for those things, and then bundling and episodic capitated payments. Patients should have what they're calling medical homes, especially if they're chronically ill. Providers collaborating, coordinating care, transparency, eliminating fraud, waste, and abuse. So these are all great things, but what remains to be seen is how this is going to be implemented. And so a lot of the proof lies in the pudding, so to speak. Unfortunately, not too many people up on the Hill, except maybe Marco Tomasi, who I don't think has been working in the healthcare industry at all, unfortunately, are behavior analysts, and so they don't understand consequences and unintended consequences of the actions, as well as important criteria of pinpointed behavior, such as is it under the performer's control, things like that. So that can pose some problems, even though the intention is so good with some of these efforts. So this is from a special comment report that came out about a month after that reform bill was signed into law, saying kind of the long-term outlook is negative. The ultimate credit effect will be negative, but many of the most efficiently operated health systems will take advantage of the opportunities to leverage economies of scale, scope, broaden their market reach, and strengthen their position. So those that understand behavior and process improvement and how to do it properly could really benefit from this, because this is going to allow them to excel. It's going to provide, in theory, provide reinforcement for doing those things properly. But the problem is so many of them have no idea how to do any of that, and that's going to make it very difficult. So kind of the silver lining, so to speak, is there's plenty of money for everyone if we work together to eliminate waste. So this is a Thomson Reuters study that identified the waste present in healthcare and associated costs to that. So as you can see, there's some pretty extravagant numbers there associated with this waste in healthcare. And healthcare is an interesting industry, I've always found, because they really, until very recently, haven't looked at themselves as a business so much, because they say, we're providing care. We don't care about money, we don't care about being efficient, we just want to provide care to patients. But we all, I think, can understand and know and agree that those aren't mutually exclusive, and obviously these wastes up there, not only are they costly, but they're negatively impacting the care that's provided. So it's not, we're going to focus on the bottom line, focus on business at the expense of quality. They tend to go together in a lot of ways. So another thing kind of going on in the healthcare industry right now is some pretty hefty reimbursement cuts. Certain specialties, such as cardiology, which we work in a lot in MedAxiom, I'll give you a quick background on MedAxiom in a minute, are being hit much harder than others. They tend to focus on those with the large dollar reimbursements, which cardiology is one of those. And again, some interesting unintended consequences. It's really driving this whole flock, really, of private practices being bought out by hospitals, which we're calling integration, mergers, operational changes in order to qualify for different billing methodologies. So this is pretty interesting, and we don't have to get into the nitty-gritty of this, but this is the Medicare reimbursement rates for a left heart cath, a cardiology procedure. The top line in red is the reimbursement when it's billed under a hospital. The blue line at the bottom is the same exact procedure when billed under a private practice, billed by the physician. The same exact thing. And so you can see by the way Medicare has changed the reimbursement structure, they're driving this, practices trying to restructure their operations in order to meet the requirements to bill under the hospital just so that they can get reimbursed more. So it's creating kind of, I would say, waste in that way. That they're jumping through all these hoops, making operational changes that may not be the most efficient or the best for care, just in order to reach that higher reimbursement level, because they have to survive at this point. there's been some scrutiny, a lot of scrutiny on over-testing. The idea that specialists are testing when it's not medically necessary in order to produce revenue because tests are highly reimbursed. There's been a lot of research that's been done to show that this is not true. A push towards disease management and bundled reimbursement, accountable care organizations are all kind of buzzwords right now. Again, the intent is good, however, unintended consequences are being overlooked. So, for example, the proposal is that there be a predetermined amount that you're paid for managing a certain type of patient. So, a congenital heart failure patient or CHF, you get a certain amount for caring for them, based on what the normal path of treatment is, the normal tests that are run for an average CHF patient. The problem is not everyone's an average patient. And so you're putting the doctors in a really interesting kind of ethical decision they have to make where they say, well, I know that I'm not really reimbursed for doing this test because that's not part of the normal treatment plan, but this particular patient really needs that test. So do I test even though I know I'm not going to get reimbursed for it, I know I'm going to keep that money, so to speak, or do I sacrifice the care of the patient and not test because that's kind of the standard path. So just some interesting things that we as behavior analysts think about the consequences and not everybody does, unfortunately. So medical error, 15 years ago the Joint Commission said wrong site surgery is a bad thing. What can we do to fix it? I think we all agree with that. So they decided they were going to collect data, which hadn't really been done in a stated, systematic way prior to that. Wow, my graphs have disappeared. Wonderful. Well, that's interesting. So there was a graph here that showed basically from 1995 to 2008, I believe, 7 or 8, over time. And so the first couple bars for the first couple of years are fairly low as far as the number of reported wrong site surgeries, and then started increasing a little. And this slide showed just the first 4 years, I believe. So basically, they were shocked to find out they're increasing. We need to get better at this. We need a sentinel event alert. So they were going to tell everybody, hey, don't do surgery on the wrong site. Because I'm sure doctors weren't aware of that before. So yeah, they tell them, hey, don't do surgery on the wrong site. That's a sentinel event alert, which was going to show up over the graph. Sorry, guys. And then in the next couple of years, a couple reports came out from the Institute of Medicine to err is human from the Institute of Medicine in 1999. Led to increased awareness for the U.S. medical errors, push for patient safety, et cetera, et cetera. The report was based upon analysis of multiple studies by a variety of organizations and concluded that between 44,000 and 98,000 people died each year as a result of preventable medical errors. So it was kind of a call to action. And then we had the Crossing the Quality Chasm in 2001, and basically called for fundamental change to close the quality gap, recommends redesign of the American health system, et cetera, et cetera. So there's a lot of focus on this over that time period. Oh, no graphs, good. Okay, so the first graph showed just the first 4 years. Now we've added the next 3. So what's going on? They're still increasing. We better issue another sentinel event alert, because I'm sure the first time the doctor just ignored it or didn't understand what we meant when we said don't do surgery on the wrong body part. So we'll just do another one, and that should definitely work. So then this happens. They're still increasing. Okay, now we really need to get serious. Let's hold a summit and design a checklist, because that will obviously get their attention. So they come up with this checklist, which, we're behavior analysts, we understand checklists, and so that's good. That's an antecedent, right? It started the timeout, so before every single surgery, still now, they're supposed to do a timeout and review the side and body part and everything to make sure everything's correct with the entire healthcare team. And so this was an effort to kind of have more of a team environment and allow other members of the team, not just the physician, to speak up if they know there's an error in that. So just kind of implementing that as part of their protocol prior to starting the surgery. So these are just pictures of the timeout, and then a couple other things. Medication administration, using scanning to make sure they're trying to give it to the right patient. Pyxis machine is for controlled substances, so you have to scan the patient that needs it. It pops out right amount. So this is what happened. They kept increasing. They got a little dip. when they first implemented the checklist, but then they went back up. So what do we do now? We'll hold a second summit. We're going to do that again. So what happens at that point? It gets even worse. So what do we do now? Despair sets in. Shannon Loewy, who said the annual meeting in April 2010, I think it's safe to say the patient safety movement also has been a great failure. Hospital CEO estimates that wrong site surgical errors continue to occur at hospitals all over this country at a rate of nearly 40 per week. So what's going on? What can we do now? We're out of options. We can't do any more summits or alerts or whatnot. So we're going to say we have a zero tolerance policy for errors. Because obviously people were just confused before they thought they were allowed, and so now there's a zero tolerance policy, which I think is kind of equivalent to teaching abstinence in school, right? It sounds great, but it just doesn't always work in practice. So this statement I'm going to read to you: voicing ever stronger concerns that the healthcare community still is not doing enough to prevent wrong site surgery, the Joint Commission on Accreditation of JCO, the Joint Commission, recently called all providers to adopt a no-nonsense, zero-tolerance policy toward that grave area. There's no excuse for performing a procedure on the wrong body part, wrong person, or the wrong procedure on the right patient, says leaders of the Joint Commission. So basically, they decide to fine and reprimand rather than fixing the process, punishing reporting and not really fixing the issue. And so a lot of us are probably aware that one reason, maybe it's true, it's difficult to tell, but potential reason that data kept increasing is because they're now telling people to report errors, which they never did before. So just the act of collecting data didn't mean those errors weren't occurring before, they just weren't accounted for. And so now, for a period of time, they started rewarding reporting. Well, the reporting went up, but now they've changed their mind, they decided they're going to punish that. So we have a zero tolerance policy, and I'm pretty sure Aubrey Daniels said this at one point, and probably a billion other people, but blame the process, not the person. So not blaming the people. So quick overview, that's just kind of my take on a quick overview of the healthcare industry at the moment. MedAxiom, to give you a quick background, which is the company that I work for, as well as Joe Sasson, who's here. It's basically cardiology-specific quality improvement networks. So there's a cardiology practice network that's made up of over 320 cardiology practices all across the state, representing over 6,000 physicians. And there's all types of benefits to our members. One is our MedExpert online knowledge base. So this is an online knowledge base. They can log in and get all kinds of information on how to run their business or practice management information, not clinical information. Really, one of our main products, as I see it, is our MedAccess benchmarking database. And so this is what's really fascinating to me from the beginning of when I got involved in MedAxiom, which is that these practice managers, CEOs, those that run the cardiovascular service lines at the hospitals, they get it. They really want to manage using data, which is awesome, right? I mean, that's so great. We talk about that all the time. A lot of people don't understand, but they do. This whole group really thrives on this data. So we have an online database they can log into, and just a quick review. This is a benchmarking report, so each one of those little tiny blue bars represents a practice, and you can see in red where their practice compares. They've got the 25th, 50th, 75th percentile lines there, and you can filter it by all kinds of different factors, group size, group location, all that. Trending, so that you can look at their data over the years, and a comparison graphing, which is really neat. You can look at pull different metrics on each of those graphs, and then on this one, the top graph has the top quartile of performers highlighted, which corresponds to the same highlighted groups in the other graphs. So you can kind of see, are the top performers on this metric correlated with higher low performance on other metrics? So really neat that these people that aren't behavior analysts, but they get data, and so that's really great. So we have a consulting division. We do all types of different consulting work, but what I'm going to talk about today is our Med Workflow program, which is processing workflow redesign. It's a unique combination of lean and behavior analysis, cost-effective approach to operational efficiency, helps with productivity, throughput, and workflow, resulting in hard dollar savings for the customers, as well as improved quality and all that great stuff. And it provides problem-solving and analytical skills training for the employees. So kind of the current state of process improvement projects with MedAxiom when I kind of came into this was more of the traditional consulting model. Consultants come in as outsiders and they do lots of observations on what's going on in the organization, and they give some recommendations and then they leave. And no one's really sure what happens with the recommendations after they leave because they're gone. And Dr. Daniels was kind of talking about this a bit next door, that's not really the most effective model for actually making improvements. So we kind of looked at this and I said, I just think we really need to redo the way we do these programs. It's not producing the results that we want to get to the clients, and it's not the right scale for us to sell to our marketplace, and it's not even profitable for the company, honestly. And so let's redo this. And so that led me to this pairing idea of behavior analysis with lean. So why did I come to that conclusion? Being a behavior analyst, I'm biased, but I found behavior analysis to be the perfect complement to lean and kind of the missing piece of the pie, which is kind of the conclusion that Dr. Daniels came to about it next door. I found the process of lean to be very similar to the behavior-based safety process, in that it's extremely employee-driven, facilitated by employee-driven, so you have a team of employees. They're actually kind of train them on the process, on the tools and methodology, and then they're actually doing the work, coming up with the solutions, which of course kind of institutionalizes it, as Siggy was talking about this morning. And they come up with great solutions, but the missing link there is they come up with these great solutions, but then they don't know how to change behavior to get the employees to do it. And it's a little better because they already have the buy-in because of the involved nature of the process. But you don't have every single person on the team, in the organization on the team. So maybe you have buy-in from like 10 people, which is better than none, but you've got a lot more. And so how do we change the behavior to actually use these solutions we came up with? And that's where behavior analysis came into play. So a lot of similarities between the processes, though. There's a big emphasis on observing. We start with what's called a Gemba walk, and Gemba is Japanese for the place the work occurs. So actually going and walking the process, doing observations, not just sitting in a room and talking about it. Focus on data and quantifiable results. We do pre-implementation and post-implementation data collection. It's different than it is in a research setting, of course. You can't do all the same things. You don't have as much time. People aren't as willing to do that when they're needing to actually see patients. But doing at least enough to show in numbers the improvements. Using kind of the experimental method. Learning by doing, similar to kind of guided practice as we talk about it. Focusing on the process, not human error. Pinpointing behavior. Like I said, very employee-driven, creating buy-in. Different from the traditional consulting model in that you coach all the way through implementation. And so we found really behavior analysis is a missing piece. And so what is lean, just quickly for those that aren't familiar? It's a management strategy for improving processes by looking at value-added versus non-value-adding steps. So what is value-adding to the customer, which in healthcare is generally the patient. Sometimes it's also the physician, depending on if it's a supporting process to what they're doing. Defining value from the customer standpoint, and then looking at, are these steps value-adding or not? The ones that are value-adding, we don't need to mess with, especially in healthcare, because that's such a small portion of the steps. If you really think about when you go to the doctor's office, you check in, you wait, you maybe get some type of triage process, you wait, you finally see the doctor for a tiny amount of time, and then you go through some checkout procedures. So, the amount of time you're actually getting value from the process is very small. So why we don't need to try to shorten that. That doesn't make sense. Maybe there's a little bit of waste in there, maybe the doctor is kind of slow or something like that, but that's such a small amount. There's so little improvement to be made there. Let's focus on all the other mess because there's so much more there that can be done. So looking at it that way, I thought made a lot of sense to me as a behavior analyst. Lean is most commonly associated with Japanese manufacturing, Toyota production system, and Deming, using less to do more, and again, employee-driven. So the goals of Lean are to reduce lead time, orchestrating operations to ever get closer to that ideal, and reduce waste. And waste is anything that adds cost without adding value. And so this is, I'm not going to go through this in detail, but this is a breakdown of the 8 categories of waste as we see them in Lean. Looking at them from a behavior analyst standpoint, they make a lot of sense, but there's some examples there, and I'll make sure that if anyone needs slides afterwards, they want to take a closer look, you can certainly get those. So the PDCA cycle is the method we use, which is basically like small experiments. Plan, do, check, act. So the planning is kind of the hypothesis stage. Trying is actually kind of doing the experiment, running, we think this solution will work, we'll try it out. Check with data. measuring the data, and then adjusting it. So using that, that model for continuous measurement of processes and monitoring improvements for kind of that continuous improvement model. So a few examples of kind of what's been done with lean in healthcare, and I thought it was interesting that Dr. Daniel said it's kind of on the decline as far as popularity, and maybe that's true in other industries, but I haven't seen that at all in healthcare. It's kind of just gaining traction, I think. You agree? Nodding your head. He's worked in this as well, worked in this area. So I guess it was kind of slower to start maybe in healthcare, and so now they're just on the upswing of it, but it's really picking out in healthcare. And so Virginia Mason is one of the big healthcare systems that uses lean. They've been using their principles since 2002, have had extravagant savings from eliminating waste, which you can see there. And kind of the lesson learned from them is you must implement system-wide. So it was initiated by a mandate for change from the board of directors following a period of economic stress in 2000. In the spirit of transparency, they clarified expectations, responsibilities, and accountabilities. They created compacts for their leaders, which was the board and the physicians. All 5,000 employees required to attend an Introduction to Lean course, and many participate in Rapid Process Improvement Weeks, RPIWs as they've named them, where the teams analyze processes and purpose, test, and implement improvements. So they've institutionalized it. They've made it part of, from the top down. It's required of every employee, and they're all participating in these events. So this is just a picture of the Virginia Mason production system. So it's based on the principles of the Toyota system after they actually took a trip to Japan to observe firsthand. And the idea is to achieve continuous improvement by adding value without adding money, people, large machines, space, or inventory, all toward a single overarching goal of no waste. So value stream mapping for them is key, process mapping. And they have 6 areas of focus. Patient first is the driver of all processes. Creation of a safe environment with a no layoff policy. This is a really important piece of lean. Everyone thinks lean means firing people because you're becoming more lean, you're getting rid of waste. If you want your employees to participate and make good suggestions, they're probably not going to do so if they think they're going to make solutions and solution themselves out of the job. So a no layoff policy is really important to get that participation from them. We found, and there's a lot of redeployment that occurs, and so not firing people, but using them in a more constructive way within the organization, and then of course sometimes downsizing through attrition. So implementation of a company-wide defect alert system called the Patient Safety Alert System, encouraging innovation and try-storming, they call it. So encouraging and rewarding and incentivizing employees to try things. And that's not the way things have always been in healthcare. It's, kind of you do what you're told. You don't suggest new things. And so that's really a change in the culture to kind of promote that and say, we want you to come up with new ideas. We want you to try, and you have to show us in the data that it works for us to do it, but we want you to try. So that attitude toward things, and then creating a prosperous economic organization by eliminating waste. So improvements seen at Virginia Mason, by reducing inventory, they were able to save $1.35 million. This is after 2 years of implementing lean. They had 36% decrease in FTEs by redeploying to other positions, decreased floor space by 41%, decreased lead time by 65%, decreased distance that people walk, basically employees walk, by 44%, and you can see the rest there. So some pretty significant results. So another example here is from ThegaCare, another large healthcare system. They had a goal of culture change with 3 tenets for change: respect for people, teaching through experience, and focus on world-class performance. And that picture there is of their visual tracking center. So I just thought that was interesting with the graphs and the data and everything up there, like we promote. And I thought interesting too, they have those tenets, but then they really kind of operationally define them, which isn't always the case in organizations. So improving quality to world-class levels, and they define that as 95th percentile or greater via quality ranking. Becoming the healthcare employer of choice, so that meant making the Fortune 100 list of best employers. Lowering costs in order to lower price paid for services, that meant gaining $10 million a year through cost savings and increased productivity. That was their goal. And participation in at least one event week per employee was mandatory for all So the savings that they saw at Beta Care, you can see again, very large, 3.3 million in savings just in 2004, saved over $150,000 in cath labs just in supply procurement. So we're not talking about changing the way the doctors deliver medicine. Trust me, being raised by a dad that's a doctor and now working with them, I would never suggest that anyone try to do that. Stay far away from suggesting how doctors practice medicine. But all these little things that are around them, optimizing those and eliminating the waste and all these supporting processes makes a huge difference. And so our med workflow process, just to give you a brief overview, and then I'm going to go through some case studies, but so you can understand the framework of how we implement this. It's a 3-step program. We do basic training first, we call it. We have little fun words for everything, but basic training is the education session for the employee team by the med workflow coach. And so teaching them the tools and methods of lean and of behavior analysis, so that when we do the analysis portion, the workshop portion, they have that knowledge, they have that background, and they can then practice it during the workshop. The boot camp is the actual workshop where we go through the detailed analysis. Approximately 1 month after basic training, and during that interim, they collect baseline data that we determined that needs to be collected pertinent to that process. It's where the detailed analysis is done, and we go through all the steps there, which I'll show you examples of all of those. But we do scoping, document to scope the process. We do the Gemba walk. From that, create the current state process map. Do waste identification from that process map. Do root cause analysis to get to the true cause of those issues, the ones that are priorities from that. Solution brainstorming from those, and then creating a future state map, and then doing implementation planning, which is a really important piece that I'll talk more about in a minute. So and they come out of that with the plan, the recommendations. We then follow them through implementation, don't just leave. A lot of it's done virtually, but that is sufficient. They have a process owner on site that really runs things, and then we kind of supervise that with them with weekly phone calls. So coach them through the implementation plan, which lasts about 2 to 3 months, depending on the different timelines. And then going back on site for one additional visit. And truly, that's more of an accountability piece than anything else. I mean, we look at everything at that point, they collect data after they do the implementation, and we look at all that, we do, future improvements, things like that. But really, it's kind of this piece of, this consultant's coming back, and I'm going to look kind of dumb if I don't have anything to show them and I don't do my work, to the consultant as well as the upper administration and positions at the organization. So keeping them accountable there. So what do we teach them in the basic training? Lean theories and methodologies, value-added versus non-value-adding, the waste, continuous flow triggers, and all of the various lean tools, which I would love to talk about for hours and hours, but we don't have time for that today. And then what do we teach them about behavior analysis? And so kind of this idea of how do we package our science. And I use the terms. I use our behavior analysis terms because I think those are the best way to describe our theories and our all of our principles. But that's packaged within this greater system. And so I would never go in and try to sell just behavior analysis by name, but once we're in there, we do use the term to get them familiar with that, and we've had great feedback on it, which I'll show you in just a minute. But we go through the basic principles and background, Skinner and whatnot, the importance of behavior analysis and management, kind of why should I care about this as a manager of a healthcare organization. Operant and classical conditioning, performance management, ABCs of behavior, pinpointing, 4 types of behavioral consequences, how to deliver feedback, and measurement systems, including balanced scorecard. So that's about the extent of it. We don't get to go into real detail in everything, but at least giving that base, really focusing on consequences, how that drives behavior. That's something that there's this incredible lack of management education or training amongst mid-level managers in healthcare. It's unbelievable. It's one of the most shocking things I've ever seen, actually. I've seen the nurse that's been there the longest is running the cardiovascular service line in the hospital, which is always one of the top 3 revenue-generating service lines in the hospital. Just because they're the nurse that's been there the longest. I'm sure they're a wonderful nurse. And they might be a good manager if someone ever told them what that means or how to do it. So there's a real lack there, and even giving them this much, they just love it. I mean, they love it. They love that they're involved in this, that someone's asking them what their opinion is, and they love behavior analysis. We actually have some quotes from clients about specifically that, which we didn't ask about behavior analysis. So what do you think of the med workflow process, which is all this combined? and they pick out behavior analysis. This is what was missing from other stuff we've done before. So it's been very effective and very rewarding for us in that way. This is kind of what we teach about Lean again. Not going to be able to go through all of it, but just to give you an idea, these are all the various Lean tools. And as you can see, are the people, highly flexible, highly motivated people are the central pillar. So again, kind of that's one of those things that I think bleeds over to how we feel as behavior analysts. Just a picture to show you kind of the process we use for process mapping and waste identification. You can't see it real well, but basically it's a real sloppy mess of a process map up on a wall. We use this really neat paper, dry erase static link paper that just sticks up on the wall. Instead of like, I can use Visio and whatever map programs and do that on my computer, but this way they're doing it. I don't write that stuff. They get up and write it. They do the process map and get it up there for everyone to share and do its kind of a workshop format. And then all those colored Post-its, each color represents a different category of waste of those 8 categories I showed you. And so we take quite a bit of time for them to really think about the process and what they're part of the process and what problems and waste exist in the current state. Pick out the right colored Post-it note, write their waste, and put it up there on the map. So it's a real visual depiction of the waste that occurs in it, and a very interactive process. So results we've achieved with the Meta Workflow program. I have some data from specific case studies here shortly, but this is kind of a more general overview. Reduction in rescans for a diagnostic imaging department by 62%, elimination of dual processes, over $1 million per year in additional gross profit for a nuclear department, decrease in patient paperwork by 50%, increase in JCO compliance by 100%. That's obviously really important. That doesn't get anyone any money, but it's very important that you're compliant with the Joint Commission regulations, which were just being completely ignored with one of our clients. So putting those into place. Reduction in chart goals with an EMR implementation. I'm going to talk about this as one of the case studies, so I'll go into more detail with that soon. But increase in revenue by over $500,000 per year just by restructuring the physician schedules. In cardiology, the physicians do a lot of different things. So putting together the schedule of who's doing what on what day, when, is like the most complicated thing I've ever seen in my life. I can't believe that that's actually how it occurs. It baffles me. So just helping to, and they have outreach clinics, and so the physicians are driving to these outreach clinics, and some of them doing so in a way that doesn't make sense, a way that's wasting physician time, which is one of the most expensive resources they have. So just restructuring that so that they weren't driving as much and wasting their time, save that much money. Elimination of a paper ordering process that was leading to errors. Decrease in average time to resolve patient issues initiated via patient phone calls from approximately 3 days per issue to 1 day per issue. I'm going to talk more about that in the case study as well. And then cost savings of approximately $200,000 by improving patient flow through diagnostic imaging and eliminating the need for an additional suite that they already had approval for, which the vendor who we were working with to do this project wasn't super excited about, but it just wasn't necessary once we got things working properly. So I'm going to present a couple case studies here as kind of a roadmap for improvement. Quick disclaimer, I know these are not rigorous research designs. That's why I'm not trying to publish them in Java. So we're aware of that. That's just not possible in practical settings, usually. Sometimes it is, which is a treat, but for the most part, especially in healthcare, if you implement something that decreases errors, no one on the face of the planet is going to let you pull it out and do a reversal design. So sometimes you can see again kind of some multiple baseline stuff, but again, you have to actually be hired to do the work in order to do it. So they're not usually going to want you to do it multiple times and pay you for that. So just letting you all know that up front. But I do think that there's practical significance in this work that's done kind of out in practice because that's what you're actually able to do out there. So a case study from Neurologic and Orthopedic Hospital of Chicago. And actually this was written up by a third-party organization as a white paper with this client, so there's more information here if anyone's interested in reading it. I can get it to you electronically. I think I have too many copies with me. But this client, this is the project charter, which is the first thing we do with the project, just to kind of get the goals, the scope, and all of that on one page. So the purpose of this project was to improve efficiency and patient flow through diagnostic imaging. The team is comprised of, it's really important to have an interdisciplinary team. one of the things that has been very shocking to me as I've done this work is when you get people from, they're in the same organization, you know, and they're not all that big. These aren't like huge hospitals. They don't ever talk. They might say hi, you know, in the lunchroom or something, but they don't ever talk about what's going on with the process. Even if they know, you know, they have a lot of errors that come down in the orders from the clinic. What's the first thing is you do as a behavior analyst? Probably go to the source of where you know those errors are coming from, right? And observe or you know, try to troubleshoot that. But that doesn't really happen. So getting this interdisciplinary team together, just in and of itself, sometimes is very, very eye-opening. So we had the director of diagnostic imaging, was the process owner. We had higher level administration and physicians were sponsors, and then also on the team, registration coordinator, diagnostic imaging techs, PACS coordinator, the clinic operations manager, the clinic RN. So we had people from diagnostic imaging and from the clinic, which is the orthopedic clinic in this instance. And kind of the issue here is, with diagnostic imaging and a lot of the projects I've worked with, is that they're servicing orthopedic doctors who need to send the patient to get x-rays and then they need to see him back. So they have a scheduled appointment and they see him at that time, but then they send him off and then they need him back. Well, you can imagine that creates a bit of a problem with from a flow standpoint, because they can't predict when these patients are coming back, and maybe x-rays backed up and it takes forever. And, so that's really kind of the issue there. So the goals for this project were to decrease order errors, decrease rescans, so an x-ray scan that wasn't done properly, that has to be redone. So decreasing rescans, decreasing the total lead time for patients through diagnostic imaging, decreasing patient paperwork completed, increasing standardization and streamlining the process. Also, they wanted a culture change, which I hear this a lot. So then, of course, we always have to operationally define what a culture change is, because that's not a good pinpoint. And the thing that they defined it as here, which was interesting, was employees helping each other. And that's not truly a good pinpoint at this point, but it's better than a culture change. So again, I'm looking, what does that mean? What behavior do you want them to display? I want them to go to the person that needs help when it's needed. That's pretty good. So that was one of the goals. The quote from the client: wait times were too long and patients and physicians were dissatisfied. We had to figure out a way to make our workflow more efficient because it just wasn't. We needed to determine where the patients were bottlenecking and what was causing the problem. So this is a SIPOC. This is what we use for a scoping document. It shows the suppliers, the input, the process, output, customers, and then stakeholders. The most important piece of this whole thing is the start point and the end point. Because in healthcare, as in many industries, everything's pretty related. So if you don't really strongly define this as a team, you can end up doing the entire organization in one little project, which is way too much to do. So here, it's from when the order is placed. So we're not looking at the patient's interaction with the physician at all. We're starting from when the order is already placed by the physician to when the image report is received. So that was our specific scope for this project. So mapping the current state of the process, and this is once we do it messy on the wall with everybody, then I make it nice and electronic. So this is more of the finished version. And it's real small, you can't see all the pieces, but that's okay, that's not what's important. Basically, process mapping, each one of these boxes is a step, and you read it from left to right over time, so it's each step kind of in sequence as it occurs. And then you have metrics underneath each step for the process time for that step. And then we have these circles in between our wait time in between steps. And so then you get the total lead time by adding that all up. The metrics underneath are populated by the data that we collect. So then that's actually true data. Then we have decision points here and diamonds. We do a whole talk just on process mapping, but we map the current state. This is the way things are currently happening. Then we go through the waste identification, like I showed you the picture of. From that, we have the wastes in categories. So you can maybe see or not see there, but those are the 8 categories of waste. But basically, this tends to be the case. You'll have a couple big categories that comprise most of the waste. So in this particular one, blue is correction, red is waiting, and purple is overprocessing. Those 3 categories account for over 75% of the waste identified. So that helps us figure out what are the biggest issues. And then we also do a waste ranking activity where the team ranks each item of waste, or each one of those sticky notes, on 2 scales. Ease of implementation along the bottom is how easily can we implement a solution that fixes this. And this is obviously kind of a guess at this point because we haven't gone to solutions yet. But is it a problem with computer systems not interfacing, which is extremely expensive to fix? That would not be rated very highly on the ease scale. So just things like that. So 5 being it's easy to implement a fix for it. And then impact to process is the vertical axis there. How much is this impacting our process? And a 5 would be high impact. And so we rank each one. These are codes from this project. But so these kind of in this top right quadrant are those that we have ranked highly on those scales. So we're saying they're pretty easy to implement a fix for, and they're a high impact to the process. So that's the low-hanging fruit, so to speak, and where we would place our priorities as far as problems we're going to fix. So we take those top problem areas and we do a root cause analysis for each one. You can use there's a fishbone diagram, or whatever it's called. I like this 5Y analysis better. So basically the way this works is you have the problem statement up top, and then you basically, like a 2-year-old, keep asking why to get down to why it's really happening. So for example, patients waiting too long in the waiting room. That's not the actual root cause, that's the symptom, that's the waste that you see, but many different things could cause that. So needing to figure out exactly what's causing that. Is it because there's no trigger from registration to the medical assistant that the patient's ready? Or is it because the doctor's running behind schedule because of a billion other reasons? So you have to get to that true root cause in order to actually fix it, otherwise you're just throwing solutions at it haphazardly. And if it's not a solution, if that's not the actual problem, then that solution is not going to solve it. So solutions for this case, changes to the EMR order entry template. This whole technology piece of healthcare is really interesting and obviously has a lot of benefits, but it has some drawbacks too. And so there's decision support, which is kind of like auto-populating things and automatically doing things in the computer system is great, but relying on it too much can really cause some problems because if something auto-populates, the doctor, the performer, is probably going to stop attending to that, right? Because they don't need to. So then if there's an error in it, no one's ever going to notice until it's down the line. So we actually changed the diagnosis field to not auto-populate because there were errors in it too often. So now the doctor has to input the diagnosis field and it's required to move forward. So programming in a consequence for vigilance. Also, we made some separate fields for each element of the order so that errors weren't carrying through. So we made a standard paper ordering form which just required circling by the doctor instead of writing because we all know how wonderful their handwriting is. So that to correct some errors, and having an MA or an RN error check the order before releasing it. So not letting errors pass on down the process so that they have to go back even further to be fixed, but catching it right then and there. The Diagnostic Imaging Pact program was kind of this culture change that they wanted. So that included data collection, feedback, and reinforcement of meeting goals for reducing rescans, protocol for how to close the case, and then data collection, feedback, and reinforcement for following that protocol. And then an and-on bell, an and-on is a main term, but it's a bell system to alert when help is needed. This was this culture change they wanted. So, quote from the client, we realized that the way this department is laid out, it's difficult for a staff member to ask for help. You actually have to leave a patient to shout down the hallway for attention. That was not optimal, so we installed a system of multiple bells, like doorbells. They're placed strategically throughout the imaging department. There are different tones for different locations. When you hear a chime, if you're not busy, you go to assist your colleague. It's working very well, and of course, the behavior analysis piece of that great solution is that, okay, but then when they do that behavior, it has to be reinforced. And so that was the missing piece in this lean program, and that's what we've taught them by bringing in behavior analysis to it. Single call protocol for adding on an appointment, patient number pool system for registration. This eliminated a double sign-in for the patients and eliminated a lot of motion from the registration personnel having to get up and check the list and things, and condensing the patient paperwork. So then this is the future state process map. Just incorporates those changes. The green things are called Kaizen bursts. Those indicate where a solution is being implemented to the viewer. And then the implementation planning is a key component of this, oftentimes left out of traditional consulting engagement. But we have a spreadsheet like this for each and every solution we come up with, and then every single little tiny task that needs to be done to get that solution. You know, we need to have a team draft up the protocol, then we have to take it to so-and-so for them to put their stamp of approval on it. Then we need to have a session to train, you know, people on that protocol. We need to develop a measurement system. Every single task that needs to be done, who's responsible for it, what the deadline is. So really spending a good amount of time to lay that stuff out before the consultant leaves, so that they have a plan that they can follow, and then that's what we review with them on the phone calls. So some data from this project. The errors and orders were reduced by over 50%. Missing orders were completely eliminated, likely due to the MA and RN check before releasing them. Total cycle time or lead time was decreased from 57 minutes to 51 minutes. Rescans were decreased by more than 60%. They went from 8% in baseline to 5% the first month after, and then 3% the second month after. So some substantial changes there. And then these are some little quotes from this white paper. We don't have time to leave them up there too long. The most important quote is this one, which just made me smile from ear to ear for, well, probably still, it's like a year later. The reason the med workflow process works, comments Payne, which was our client there, is because it's built on quantitative and qualitative data, which is a distinct difference from traditional process improvement. This process incorporates behavioral analysis. They'd never heard of this term before we worked with them, which is critical because you're not going to be able to improve any process if you can't get buy-in from your people. So this was really my goal with all of this, and so it was exciting to see that come to fruition, which was to deliver behavior analysis in a way that they understood it and they got it and they were going to now use it in practice. And another comment here is, you know, we didn't stop. Once Shannon left, we didn't stop. We felt the process was very solid and that the information obtained had extreme value, so why should we stop? It has been and will continue to be a success. We've been able to change process all the way up through senior management without much hesitation, blah, blah, blah. So I think that's really the goal with consulting work, is to leave them with something sustainable, institutionalize it, and to our science, to not change our science, not degrade our science, but to get it out there. And we may have to, you know, to do so in an interesting way in order to get it in front of people. But once we do, it speaks for itself, I think. So that's been my experience, at least. This is one more case study we're almost done here. So solutions. This was with the EMR implementation. EMR is electronic medical records, which is running like wildfire through the medical community, and it is going to be, people are going to be penalized for not having such systems in place very soon. But there's a lot of process change that goes along with implementing it. So we've done a lot of work with that, but basically trying to reduce the reliance on paper charts, because we have a lot of people we've heard go to EMR, which is making everything electronic, no more need for paper, and they triple their paper expenses. So trying to help them not have that happen and faster service their patients. So chart pulls, you can see here, decreased. They were 100% chart pull, and this was for actually phone triage, so when patients would call in with issues, which has become a way that groups interact with patients very, very much a lot. And so they were pulling a chart every single time they got a phone call, and that we decreased that to 40%, only 40% chart pulls before they even implemented the EMR, because we determined through data collection that a lot of the calls were, you didn't need that patient's chart, they were a general medical question. You know, can I get in the hot tub when I'm taking this type of medication? The answer is always no. You don't need a chart for that. So that was really interesting. That kind of set up the culture. It was such a culture change of we don't always need a chart in front of us before they even implemented the EMR. Then after they implemented the EMR, 3 months after, they were down to only 8% chart pulls, and 1 year after, down to just 1%. Days to resolve the patient issue when they called in was averaging 3 days. You know, they took some notes, they had to leave it for the doctor, who then put it in his car for 2 weeks, and whatever. Down to 1 day on average, fielding a lot of those, right then and there that could be taken care of. And then calls transferred to the pod, they were only going to transfer to the pod, which was the doctor or the pod nurse, when they had to be, not every single time, which was how it was happening. So it was 100%, down to only 66%, I believe. Some quotes from that client. The bottom one, really important. That's what was missing from other projects. This is a group that had a lot of experience with Lean and Sigma and had done projects with other companies and all that, and they felt that behavior analysis was the piece that was missing. So my final point, this guy makes me so mad. Nikki Gravina, Cole Gravina, who's sitting in the other room right now, and has a very similar message we found out last night in our presentations, sent this to me a couple years ago. This guy was on the 2009 Times Magazine Top 100 Most Influential People list because he made a 5-item checklist that helped prevent hospital-borne infections with surgical patients there. A 5-item checklist, and he's on the Times list with Barack Obama that year. And it makes me so mad. It's great that it's being done, and he had great results and saved a lot of lives. And actually, Atul Gawande, who wrote the Checklist Manifesto, made a comment about this Dr. Pronovost. His work has already saved more lives than that of any laboratory scientist in the past decade. So it's really substantial. It's needed in healthcare. Healthcare is open to it now. But this should be us. We should be doing this. We can do it better than all of them, I'm sure. We know more about behavior. We understand it better. So that's why this always makes me so mad. I come back to it a lot. All right, I think we're about out of time, but please let me know if you have any other questions. I'll be around for a little bit here.